So the next kind of movement is functional and parafunctional movements. Functional movements are usually what we do, movements of the mandible when we are doing normal functions like facial expression, swallowing, chewing, etc. So swallowing has three phases: oral, pharyngeal and esophageal phases, and chewing cycle involves mouth opening, foot contact, crushing, then tooth contact, and then again mouth opening. These are all reflexly controlled, and so patients having difficulties in chewing and all will not be able to reproduce proper mandibular movements during jaw relation. Next is parafunctional movements. These are habitual movements like whistling, whistle blowing, nail biting, etc. Whereas there could be some form of parafunctional movements that are of systemic origin, like neurogenic causes like bruxism. Bruxism is no longer caused due to dental interference, it's only due to neurogenic causes. Apart from this, mandibular movements can also be classified as movements towards the outer margin, border movements, and the movements within the border movements called intra-border or regular movements. So to record the border movements, we need to visualize exactly how the mandible moves. So border movements can be measured in the sagittal, frontal, and the horizontal plane. So this is a sagittal plane view you can see, and this is the frontal view. So when the patient opens a mouth wide to the maximum mouth opening position and then closes back to the maximum right side and then goes back to the centric point or the centric relation or centric occlusion, and then they come to the left side and again go to maximum mouth opening. So this kind of, when we trace this path, we get the shape of a shield, and it's called as a shield tracing. So the next thing what we are seeing is the movement of the mandible in the horizontal plane. So that is called as the horizontal tracing. Here you can see that the patient's moving to the right lateral, again to the most protrusive point, to the left lateral and back to centric relation. So this produces a rhomboid shape tracing. It's also known as the rhomboid or diamond tracing. So CR is the position of centric relation and CO will be centric occlusion. That is occlusion or maximum intercuspal position. So when the patient tries to move the mandible forward and backward, you will notice that the incisors hit each other. So the teeth will have to move a little bit downward and then go back to maximum intercuspation position and then to CR. From CR it can go on either sides. Just remember, CO means centric occlusion. Maximum intercuspal position is also centric occlusion if the CR and CO are the same. When you see from the side, you get a beak tracing. The terminal hinge is the one which was shown, that is the pure hinge movement, and then rotation after translation. So you see the closure of the mandible also occurs around 2 axes of rotation. Then during protrusion, the incisors hit, so it slightly opens up, and then you go to protrusive point and then you close. So this is how the tracings are recorded, and when you combine the tracings on all the 3 planes, you will get what is called as the Posselt's envelope of motion, which he proved in 1953. And this shape of this envelope of motion is known as the Swiss banana. So with that, here you can see that the beak tracing when you see from the side, the shield tracing from the front, and the diamond tracing from the top. This is the shield tracing from the front, and you can see the diamond tracing from the top. All these 3 structures together is called the Posselt's Swiss banana. Posselt introduced this in 1953.